Daryl Palmer, and I'm with Janus Choice. At Janus Choice, what we do is we facilitate healthcare transitions for patients that are moved from the hospitals to like a post-acute care stay. So that's like skilled nursing facilities or rehabilitation. Now, the reason that we do this, one side is because of our experiences of our founders and going through the discharge process. The other reason why is when you're talking about these healthcare providers, they're great at improving clinical care, but it's hard to translate that into money. And so we focus on the financial health of these providers and let them get maximum value out of great clinical care. So I'll start with a story. Start with my mom, Mary. She was, at a young age, very good at languages. She spoke a lot of foreign languages fluently. She ended up being a foreign language teacher. And so as the only son, of course, you have that feeling that it's your responsibility to take care of your parents. And one day what happened was when I went to visit my mom, I noticed that she couldn't focus and that she had a hard problem communicating. And so I knew the warning signs to look for. The next thing, we go to the emergency room, and they're saying that, you know, something happened, and they placed her in the hospital and ran lots of tests. And so the next few days, of course, you know, I'm talking to her neurologist. They're saying that, you know, I was lucky I found the right things to look for. I brought her in immediately, no permanent damage, and they say that, you know, she'll need some extra care or something after leaving the hospital. But he didn't really go into that detail that much. What happened after that was that a nurse comes in and hands us a sheet of paper, and this is an example of what you would get now from most of the hospitals in the United States. So they had a stack of papers, and they said, the doctor has decided that she will still need some special care. She can't go home right now, and that I need to make a choice. And I have to choose somewhere for her to go for care. And so they give me that list. There's like 70 people on that list, and I had to go through, and I'm like, well, how am I supposed to figure this out? You know, I'm here with my mom. I'm going to have to take tours. I'm going to have to call. I didn't know what to do. And as you know, I'm really big in astrophysics and science and stuff like that. But it's very humbling to be put in a spot where you don't have a lot of information. Even if you go onto the internet, you can't find the information that you think should be out there. And so what happened is, of course, you fall back to the second step. You ask them, where should I send her? And because of the complexity of the laws, they can't tell you where to go. It is your choice. They can't steer you. And so she said, you know, well, the doctor be willing to wait 2 or 3 days, go and try to find information on your own, go to the government websites and look this up. And so, you know, it was very frustrating. There was lots of course, stress and fear of what if you make the wrong decision. Now, this is a problem that's very big because when you're looking at just in the United States, more than 30 million people a year are discharged to these facilities, whether it's a skilled nursing facility or a home health agency. And so 95% of Americans will go through this at one time or another in their life, either for them or for their loved one. Now, this is a big problem for hospitals because, you know, right now hospitals are taking on more risk. Hospitals have to improve outcomes, not just in the hospital setting, but you're talking about across the entire continuum. And so the other thing that they have to do is that they have to now try to lower the cost of care. So it's not only that you get great care, but you have to get great care on a budget. The other problem with these post-acute care providers is they have what's called a heads-on-bed problem. So if you look at Lutheran Senior Services, which is a very great set of facilities here in Missouri and Illinois, they have improved their length of stay by 30%. So they have gone down, you know, from 20 to 25 days down to like 16 to 19 days, which is awesome. You know, you get out of there faster. But their problem is because you decrease the length of stay by 30%, just to keep the same number of patients in that facility, you need 40% more customers. And so now their problem is, yes, they can do this clinical care side, but outreaching and improving their customer base by 40% in a short time is very hard. And then for patients, patients are, when you talk about this post-YouTube, post-Facebook, post-internet generation, you expect the information to be there, you expect to be readily available the way you want it. And so when the nurses come there and hand you paper or hand you brochures like you get from a concierge or hotel, it's a very startling reaction. And so what we did instead was we came up with a set of mobile and web-based solutions. So now right from the bedside, the patient and the family can see what choices are out there. They can access information that they're interested in. They can see a virtual tour of the facility itself along with quality indicators. Now, what we have done with our solutions, we actually had 2 pilots. And so when you're talking about ACOs, or these accountable care organizations, they are on the line for your outcomes, and they also want to make sure they make money out of their ACO. Setting up an ACO is not cheap. It's like $1 million to $2 million. You have ACOs one year that go from making $5 million to another year about losing $7 million. It's a razor's edge that they're dealing with. And so just from our solutions, they are able to increase the revenue that's in their ACO. So they get some of that savings from there. They can lower the total cost because now less patients are coming back to the hospital for readmission. But the other thing is they improve patient experience, because now when you're talking about this consumerism in healthcare, how the doctors, nurses treat you and your experience really matters, because everyone is fighting for patients today. Now when you're looking at our technology, my background is data analytics, so on the back end, there's a lot of analytics going on to match your clinical, financial, and social needs with those best providers that are out there. But the truth is, still people are making the decision. And you're talking about building trust and making people do things in a situation where they're under high duress. And so there's a lot of persuasive technology also in here, persuading the patient and the family that, maybe home is not the best place. Maybe a better place is going to this facility for 2 weeks and then transitioning home. Now the other thing that these post-acute care providers, they're interested in, is they're interested in what do patients want. And this is not just clinical care. You go to some of these facilities, they have restaurant-style dining, they have a mini putt golf course, So if you're talking about these amenities, what amenities are patients wanting, and which one will actually move the needle for them? The other thing is, we have 2 patentable technologies here that we're looking at patenting, and it's really more of the side of when you're talking about how to persuade or nudge patients, how can we do that effectively? That's what the patents are. And so this is not just an app, this is really a platform. And so at the core, what Janus Choice is we use persuasive technology to nudge patients, but we also have a lot of data that's private and public that we curate on these post-acute care facilities. And so you can think of it like a match.com, right? We find the right match for you, because even though you're a patient with stroke, maybe you're not exactly the same as another patient who's a stroke survivor. Now, we've touched multiple points, of course, the ACOs are interested in, not just patient experience, but we're also talking about, they're interested in outcomes, they're interested in standardizing care, because you're talking about a hospital system that has 12 hospitals. They want to make sure that the same process happens across all 12 hospitals. Now we have a proven go-to-market strategy, and our strategies, of course, are around the hospitals that we're involved in. And so for each hospital, here's an example of one that's in the Chicago area. Just in 10 miles of that hospital, there's over 50 skilled nursing facilities, and there's over 150 of these home health agencies. And just on that one list I printed out, just for one zip code, within 7 miles of that zip code that patient wanted, there was over, 200 facilities to go to. And so if you're looking at it, even if you're going to spend 10 minutes on the phone to call 200 facilities, that's like 3 straight days of work and effort. And so about our team, our founders, it's Sasha Goodwin along with myself. And we both come from more of a science background, astrophysics background, but work with a lot of data analytics, working with a lot of artificial intelligence. But also on our team, we have people from healthcare background experience, and people who work in a post-acute care facility, people who worked on the operations side. Now, when you're talking about our board members, we selected, of course, an outstanding board made up of CEOs, some of them in healthcare, some from digital marketing, because we were talking about selling to hospitals. Selling to hospitals is a big process, and you really need to make sure you have enough experts in your team to go after hospital selling. And so we're looking at the traction that we've had to date. So we are in over a dozen hospitals right now. We have more than 50 of these post-acute care facilities signed up. So we're working with health systems now in this quad state area. And we're also talking to some nationwide providers. The bigger the provider is, the bigger this problem is. So you have some providers that are in 20 states, and they might say, well, this is not a problem in New York, but this is a problem in 3 other states that I'm involved in. Now, when you're thinking about, the reason we had a big board and a team and everything else, is we wanted to test as much as possible our process. And so we're looking at the 2 successful pilots we've had, the rollout to the 12 hospitals and deciding on these post-acute care facilities. We've done that on less than $200,000 we raised. And so some of our competitors require millions of dollars to be at the same point that we're at right now. That's it for my presentation. Thank you for listening. But our final ask is introductions. Introductions to accredited angel investors, and also introductions to hospital systems and post-acute care providers. Thank you.
All right, hold on. So we always ask first, and then we're going to ask all the audience for questions. But the first question we always ask is, obviously you said you're asked, what can the community do for you? And it looks like you already answered our question before we came and asked it. So I'd like to open up the microphone to people to ask questions.
So you had in the circle compliance. So what do you do to help? Is that HIPAA compliance or other compliance?
Yeah, so when you're talking about compliance, one part of it is you have to be able to make the choice. They can't steer you. So we document that choice is provided. The other thing is what information is given to you. So now the laws are changing, saying that all hospitals have to provide quality information to you. And so if you look at that sheet that I just had out right there, which is from a major hospital system, that's what you get. You don't really know much on there. All you know is that they take an insurance and they're close to you. And so we provide more information to make them compliant for that.
So you don't get involved in HIPAA compliance?
No, we do have a HIPAA-based solution. So yeah, so when you're talking about, we have a HIPAA and also a non-HIPAA one. So all the results that we've shown right there, they're using a non-HIPAA solution.
Yeah, because I couldn't figure out how you would do a post-acute care transfer without really understanding the diagnosis, which starts to expose HIPAA information.
Right. We know what clinical care they require. And so from enough indicators of the type of clinical care, we can assume which diagnosis categories you're in.
That makes sense.
Darryl, can you talk about your competition a little bit and maybe what advantages you see versus those other competitors you have?
Yeah, definitely. So when you're looking at our competitors, you can break them down into majorly 3 different buckets. You have one bucket that's really big on the internal operations side, like that one that's printed out from Allscripts. They're an EMR company. They know how to automate the back end, the flow of the data. And so really still, but they're cutting out the patient and getting the trust from them. You have another bucket of people that more do just brochures, right? So you might go on there and they make brochures, information for you. And so what happens is, like, if you're talking about you want to send your mom somewhere, someone handing you a 2-page flyer, whether it's electronic or not, is not really going to convince you to send your mom there for 2 weeks, right? And so then the third one is more still the side of if you're going to go there onto the government websites, whether it's federal or state, and put in indicators right there. The problem there is they don't really explain it the way you understand it. They really take aggregate numbers, and it's not really targeted for you. So the way that we're different is that we look at your clinical, financial needs, social needs, and we match it. So we've had some people that, they know that top down, the best match is at the top, and they go down. And one woman actually picked a facility just because they had ice cream, free ice cream. They had an ice cream parlor. So, of course, it's great that, she picked the third on the list. But if you're saying that, if you told some of these post-acute care providers that they could get a patient just by giving free ice cream, they would. Because each patient to one of these facilities is $15,000 of ice cream. So if you went to a car dealership and you said if you gave away free ice cream, people would buy a car, everyone would give you ice cream.
Thanks for the presentation. Question, and then maybe a little bit on question. The first one, I saw an interesting point, and I apologize if you covered it and I just didn't understand, but you noted that you were agnostic to EHRs or format, and that's a pretty impressive claim considering there's common codes and things, but could you expand on that a little bit?
So this is where we're talking about. It depends on which system people want, and so we had all of our improvements. They didn't require any PHI information, and so what would happen is that when patients made a choice and they made their selection, we provided data into the EHR EMR system. We didn't pull data out, right? Because you can always push data in if you're very careful on not getting PHI. But the second you get any information out of the EHR EMR system, it becomes under the auspices of HIPAA. And so we are also compatible with multiple EHR EMR vendors too, but as you know probably that the vendors, it's in their best interest to slow down interoperability as much as possible. And that's just the reality.
Certainly. Thanks, that makes a lot of sense. And then I guess the second question is maybe a bit broader. Towards the end you mentioned that your burn was about 200,000, which compares to millions of your competitors. What do you attribute that to, that success of being at the same place?
Well, I mean, when you're talking about when we had our pilots and stuff like that, the first pilot, of course, was a lot of people would say, geriatric patients don't like technology, right? And even recently, Cleveland Clinic came out with an article that said, they found out 61 to 70-year-olds will use technology for healthcare, even if they're not using it in everyday life, right? And so, that was the first pilot on really seeing what's the right factor to have, what information to have. And the second one is when we delve more into the financials. And so by these small pilots, we just built on other success. And then, when we're going out to market to these hospital systems, a lot of hospital systems are unfortunately losing money. And so they want any lifeline they can get to make their ACO make money. And so even when we look at today's market and everything else and the politics, the truth is healthcare is expensive. And there has to be caps on healthcare. And so whether it's value-based payments or whether it's block grants or something else, hospitals have to survive with the reality that their revenue and income is going to come down per patient, right? And there's more competition, and that's not going to go away.
Okay, thank you.
Right.
Any other questions?
So that report is pretty overwhelming, and the old saying is too much information is no information,
Yes.
right? So do you have a way of simplifying and rating it? And then I have a follow-up question.
Yeah, so what we do is, this is why, when we're talking about the data we use for the rankings, we don't show all of the indicators and values of that. Right. So you can think of it like when you go online and you look at your credit report, right? Mm-hmm. You see various thumbs up, thumbs down indicators, but they don't go to exact detail of why exactly was it this number.
Right.
Right? And so it's really, providing the information that people want at a speed and a way that they can absorb it. And so before, when people get the list like that, it takes 2 or 3 days to make a decision. With our solution, people have made a decision, 80% of them, in 15 minutes of being in the hospital. So even, they didn't have to go out there and even do a tour. All the information they had was right there at their fingertips to make that decision easier.
That was my follow-up question. Do they get presented the information, make the decision before they leave or after they've left, so while they're still in the hospital, right?
Yeah, while you're still in the hospital, you have to make the decision before you're discharged.
Right.
Yes.
Yep.
He was next. He was next, Shane.
How many beta users did you have when you rolled this out initially?
So we had our one pilot at a large hospital system in Cleveland. We have more than 2,000 discharges that were done with that. We did our other test. It was again more than another 1,500 patients. So we had about 3,500 discharges under our belt, and we knew from experience, what not only did the patients want and need, but you also have to understand these are nurses that are doing this too. And so nurses have a lot of stuff they have to do each day. So we really have to work seamlessly with the workflow.
So you went to like the nurses and things like that, like did you door knock these nurses like, hey, can you help us roll this out or something?
No, we targeted, you're talking about the person who's one of the entryways, chief operating officers, chief financial officers, sometimes the people that actually form the ACO, because they know, their job's on the line if the ACO doesn't do well.
Gotcha.
So my question would be, what's your strategy to let the doctor to adopt your solution? I mean, the doctor group is very difficult to deal and adopt new things because they're just very busy and all kinds of different reasons.
Yeah, so when you're looking at various doctors and physicians, because we're looking at physician groups outside of hospital stays too, they have to spend only 6 or 10 minutes with the patient. They have to go in and, when they do the rounds, whenever you want to see a doctor in the hospital, either you see them at 6 in the morning or you see them at 5:30 at night, right? Because they're very busy. And so from their point of view, anything that can provide value to their patient, but in the same way doesn't actually impact care, has a positive impact. This is why, when we're talking about one reason how we're different from others is because we curate the information and we match it, right? And we are neutral in how we match it and we rate people. Some of the companies, especially the ones that are just marketing, they just market who pays most. And if people have a bump in their quality or something else like that, and they know just by paying you $10,000 a year, they can get more patients, they would pay you $10,000 for marketing just to get more patients. But that's not what the hospital wants.
All right. Thank you very much.
Okay, thank you.